Okay. I'll go ahead and lead off, and then John can jump in, and Tamara and others. I just was going to, one, welcome everyone who's attending this, go through some slides that kind of outline this study very briefly in the hub and spoke model, because not everyone maybe has heard it before. And then we're kind of all starting from the same point for the rest of the discussion. So I'm going to go ahead and share now, and someone can let me know if I'm doing it correctly.
We have
If
someone
something's
that can't
already being
hear.
shared.
Yeah, someone can't hear. I think Annette's helping that person. Yeah, dial the yeah.
Is this showing right now, the screen?
Yeah.
Yes.
Okay, I'll
Yes.
put it in slideshow now. And
Okay, great.
I'm not seeing slideshow. There we go. All right, that's looking okay.
Yes.
All right. Okay. So here we are to discuss the CSAP study, and really to focus on the hub and spoke model. And again, this is on behalf of myself, John, Tamara, the rest of study leadership. So why are we doing this? And this is a number for not so long ago. I mean, we're a few months past this now. We're actually up to 70 recruited as of a few days ago. But we're lagging in terms of where we should be at this point. And the total recruitment goal for the study is approximately 360, and we should be, getting close to halfway now, or about halfway, and we're not. So this is why we implemented this hub and spoke model that we're talking to you about. So I just briefly go to the very basics of the study. The study objective, the primary one, is to assess, number one, the superiority of pimavanserin versus quetiapine in the treatment of Parkinson's disease psychosis using the CGI, Clinical Global Impression of Improvement for Psychosis. And if the superiority is not established for either medication over the other one, then to assess the non-inferiority of quetiapine for the treatment of Parkinson's psychosis. In addition to the CGI-I, we also have the SAPS-PD as a rating scale. We have the MDS-UPDRS motor score, part 3, a CGI-I Parkinson's, and burden interview for the care partner. We're also assessing cognition using the MoCA, nighttime sleep and daytime sleepiness using a couple of instruments, patient participant function and well-being using the PDQ-8, and investigate changes in tolerability using standard adverse event reporting in a form called the TESS. And the study design is multi-center. So we currently have 15 sites, research sites. It's a randomized trial where participants are assigned to quetiapine or pimavanserin for 8 weeks of treatment. Double blind, so neither the participant or investigator knows about the treatment assignments during the entire study. It's a comparator study, of course, the 2 active treatments, and it's a block randomization based on the MoCA cutoff into higher and lower strata of cognitive impairment or cognitive functioning. So we're just about through with the CIRB in removing phases 2 and 3 from the study. Hopefully that'll happen very soon. So that's why I only mentioned the 8 weeks of treatment, which is currently what we call phase 1. There won't be a phase 2 or a phase 3 shortly. So the hub and spoke model. So current active study sites, the 15 that I mentioned, are serving as hubs and referring physicians at non-study referral centers, so they're not engaged in research, serve as spokes. Once the referred patients are enrolled in the study and become research participants at the hub, or also known as the existing study site, the study's fully virtual option is implemented, which means all study activities are performed virtually through the hub. So essentially, the responsibilities of the referral center or referral clinician are essentially done at that point after the referral. So what are some of the changes we had to make over time to implement that? So many changes to the protocol. We got approval from the CIRB for a fully virtual option that would allow this to happen. We received ORD approval for proactive calling, so sites can receive contact information for patients and do pre-screening and call them and do screening. Received CIRB approval to remove baseline labs and baseline follow-up EKGs. In exchange for that, we had to add in a little more information about excluding people with a history of persistent low magnesium, potassium, or sugar, glucose, that would put the participant at increased risk for long QTC interval. We received CIRB approval that the spoke is not considered as conducting research, so no local IRB activity is required at the spoke. And in the process I've mentioned already of removing phases 2 and 3 from the study. So setting the stage, we also implemented DocuSign for informed consent, so it could be done virtually, form changes, training administering a virtual MOCA, training on doing a virtual partial MDS UPDRS Part 3 score with imputation through a computer program for the total score, allowing use of a portable blood pressure and pulse monitor for orthostatic measurement, although not required, and pharmacy changes, numerous ones had to be implemented. So what's the role and expectations as we see it of the referring clinician? We should only refer a patient with a diagnosis of idiopathic PD. That's what the population is, that has he or she having clinically significant psychosis that would warrant treatment clinically. Should believe that the patient meets the inclusion criteria for the study participation and are not aware of meeting any exclusion criteria. Need the permission of the patient to have his or her contact information forwarded to the study site, identified via the National Study Coordinator, that's Tamara, that the patient could be contacted and pre-screened. This permission should be documented in a CPRS note in the patient's chart, mentioning that the patient has given agreement for this. Pre-screening, so once the information is given from Tamara to the spoke clinician, providing the study coordinator at the identified site, so contact can be made, creating a link between those two. The spoke again can send an encrypted email to the hub, providing identifying information, last name, last four social security, phone number, to the hub to allow pre-screening of the CPRS chart via GLV or Google. Hub site can then contact the patient or the care partner via the proactive calling to gauge and provide study-related information. And if appropriate, the patient and the potential informed other are interested, a consent date can be scheduled and enrollment and formal screening procedures begin after the consent is obtained. The referred patient needs to be enrolled at the study site center. This needs to be done through the registration office at the hub or the study site VA. They're not transferring their care, they're just being enrolled in an additional center to allow documentation to occur in the receiving site's CPRS. And this should be done before the informed consent process. Randomization and study visits. So once a patient is identified and pre-screened, screened, and seems appropriate for randomization, it's a similar process to the site's own virtual participant if they had one locally, with study documentation occurring in the CPRS chart at the site, not the patient's CPRS chart at the referral center. And of course, at some point, wherever the appropriate point is in this whole process, the receiving site should be letting the referring clinician know what the outcome of the referral process was. Did they make it all the way to randomization? Were they not appropriate at the pre-screening phase, or so on, whenever the appropriate point is. And our goal is to have this happen as expeditiously as possible, that we should be able to randomize a patient within 1 to 2 weeks of referral from a clinician at a spoke to the National Study Coordinator, but our goal is to do it as quickly as possible to not so treatment can be initiated. So we've paired sites and referral centers. I think, the number grows, but we currently have maybe around 50 referral centers paired one-to-one with the 15 sites. Primarily PD consortium sites have been added so far. John has worked tirelessly to do this, and with help from Tamara. We've reached out to neurology chiefs and geriatric psychiatry provider listservs recently to see if other VAs are interested in being referral centers, and we've gotten some positive responses from that. And this is a summary. So if you have a potential, this is for the referral centers now, if you have a potential patient to refer for pre-screening, we have Tamara's contact information because we want her to hear first so we can keep track of the process and make sure referrals are going to the appropriate sites. And she has a phone number and she has an email that's listed here. And the most important thing is that this is a huge benefit to the study. I mean, we realize now that we're not going to be able to meet our recruitment goals just based on the 15 sites we have, that we really are dependent on this referral process now, the hub and spoke model. So it's a huge benefit to the study and therefore to PD patients and family members, the field and the VA, if the spoke is able to assist in randomizing participants, referring and hopefully randomizing participants. And if, even if a referral center had one patient per referral center per year, one patient, in addition to what the sites are expected to do at their own, local institution, then we would be able to complete study enrollment in several years, and which would be great to meet our recruitment goals. So I think that was the last slide that I had. Yeah. So I'm going to stop sharing now. And before, I think John should have the next word as the.
Thanks, Dan. Yeah, I mean, if anybody has any questions, feel free to throw them in the chat or to speak up. But essentially, we are desperate and we're trying everything we can to meet our recruitment goals. And we think this is hopefully a model for future research efforts, wherein in the VA in particular, with such a wide-reaching network of providers, we can recruit to trials with virtual participation from all over the country. But we're relying on you guys, and we realize that we're basically asking to do something without compensation or any real reward other than being recognized in future publications. But like Dan said, we're hoping that the satisfaction knowing that you are contributing to the benefit of Parkinson's patients with psychosis down the line will help. And we're trying to make it as easy as possible for you. We do have some other materials to help with that, including a pocket card and some other things that we're going to go over. But does anybody have any questions? We, Alexandra, we did reach out to geriatric psychiatrists looking for referring physicians, and frankly, we're trying to see if we can get the physicians we have referring and enrolling patients right now before trying to enroll a whole bunch more referring physicians. I mean, we have enough, and so far we haven't enrolled a single patient in the study from referrals. So something still isn't working, and I think if we try to, just flood the system with more referring physicians, we may lose a little bit of that personal part where Dan and I are available whenever you want. My phone number is freely available, as is Dan's. And if you have a question about a patient, obviously we'd like you to reach out to your referring physician. I mean, your hub physician first, because it was know about the study as well. But if there's anything we can do to help, let us know. And I guess we can move on to the other materials that'll help you hopefully keep this in the top of your mind as you see patients. You want to go through this, Dan? You want me to?
You can go ahead. You're on a roll.
Okay. So we put together this pocket card that includes the inclusion and exclusion criteria. Scroll down, as well as a couple of the instruments that we're using, and we're not necessarily asking you to do any of this. It is not your role necessarily, but we thought some of you might want to see it, and just to get an idea of what kind of patient we're looking for. So let's go back up to the top again. Well, actually, sorry, let's go all the way down to the bottom and start with the modified UK brain bank criteria. So hopefully some of you are aware of the modified UK Parkinson's disease brain bank criteria for clinical diagnosis. We are using a modified version of this because, as the name suggests, the UK brain bank was for not necessarily for clinical trials and not for clinical trials early in the disease course. So we made it pretty easy, I think. We're diagnosing Parkinson's disease as the Parkinsonian syndrome, which means bradykinesia, and then at least one of the other features, which are rigidity, resting tremor, or postural instability not caused by other problems. So you need that, obviously, make a diagnosis of PD. And then excluding a couple of things that we really think make it unlikely that it's typical, Lewy body Parkinson's disease, including what looks like vascular Parkinsonism or history of repeated strokes and stepwise decline for supranuclear. That's not right. Sorry, we need to correct that. Let's see. It should say supranuclear gaze palsy. You just take out the of Parkinsonian features. I think that. Wait, let's see. Something got shifted somewhere. Features. Yeah, I just hit delete there. Hit delete again. Sorry. Or if you just no, sorry. Put that back. Control V. Now go after progression. Get rid of progression. And there you go, supranuclear gaze palsy. So yeah, if you have prominent supranuclear, now leave all that in. If you have prominent supranuclear gaze palsy, obviously, and you're thinking about PSP, want to exclude those. Moderate to severe cerebellar signs, suggesting it might be MSA or something else. Early severe autonomic involvement, also suggesting MSA, and the dementia with onset prior to within 1 year of the onset of the Parkinsonism, suggesting it might be DLB. So we're just trying to rule out DLB, MSA, PSP, and vascular Parkinsonism. And now let's go back up to the top. The inclusion criteria for the study are obviously veterans, 40 years of age or older, English speaking, although I thought we had we didn't have an exemption. Anyway, if you come up with someone who's non-English speaking, let us know. Maybe we can do an exception or something. Diagnosis of Parkinson's disease with the criteria down at the bottom, the modified UK brain bank criteria. Who has psychosis with a neuropsychiatric inventory score of greater than 4, and we'll go back to that in a minute. A stable dose of PD medications and PD interventions like PBS for at least 2 weeks. And if they're on a acetylcholinesterase inhibitor, like Aricept or Glanzine or something, it has to be prescribed at least 3 months prior, and no dose or medication change in the past month, because as many of you know, sometimes anticholinesterase inhibitors can effectively treat psychosis in some people with PDD or related problems. And then a few exclusionary criteria: psychosis symptoms severe enough to preclude enrollment. If someone is acutely psychotic, we can't enroll them. They're acutely psychotic to the point where they're a danger to themselves or others. We don't want to hurt anybody by trying to get them enrolled in the study. And obviously, this can't happen in one day typically. So if somebody needs to be treated today for their own safety or the safety of others, please just do that. And then regarding previous administration of the 2 study drugs, they can have been on either one in the distant past. Let's say they had an episode of psychosis a year ago. They can have been on either of the medications as long as they didn't have adverse effects. Like sometimes we'll put people on an antipsychotic and then take them off after a while. That's okay, but it has to be at least more than 3 months. And with quetiapine, we are allowing low dose treatment as long as it is stopped for at least a week prior to study randomization. So anybody on 50 milligrams or less, you can actually stop it and then enroll them. As I said, deep brain stimulation, surgery or manipulation is also an exclusion criteria if it's recent. And then some patients, it's not that uncommon, will have some history of psychosis prior to PD, especially it may show up in the chart. And you all know that sometimes things end up in the chart that maybe shouldn't be there. However, we are leaving up to your judgment, and it's really the judgment of the hub clinician. But when you're screening people, keep this in mind. If somebody had some kind of psychosis back in their decades ago or years ago, and then they developed PD, and then they got psychosis now, and you really think that the psychosis is due to their Parkinson's rather than any underlying psychotic disorder, that's okay. But if you're not sure, then we don't want to be trying to treat schizophrenia in this trial. Suspected atypical Parkinson disorders, like I said in the bottom, with the modified UK brain bank criteria. Psychosis secondary to any toxic or metabolic disorder. Obviously, we don't want to be treating enrolling people with delirium. So if if this is not a kind of chronic problem that you've been following, and it's an acute change in a veteran's presentation, we do encourage you to think about that and consider doing routine metabolic labs to make sure there's no UTI or dehydration or some other problem before referring them. And then, as I mentioned, if they tried on quetiapine or pimavanserin previously and couldn't tolerate it, then they don't qualify. And then we actually also modified this over the course of the trial. We've always taken people with PD dementia, but we're willing to take people with pretty significant dementia down to a MoCA score of 5. So, we need people who can talk, who can report their symptoms and everything. But if they don't remember what they had for breakfast, that's okay. Or you know what I mean. It is. These agents are obviously used a lot in patients with Parkinson's disease and dementia, and we want this trial to be as real world relevant as possible. So we don't necessarily expect you to do a MOCA or anything, but don't be afraid to refer patients who have some dementia, as long as you are confident that it didn't start before or within a year of the motor symptoms. Sometimes that's really hard to determine. We get that. But, that's where your hub LSIs can perhaps help out. And then just so you know, we put in this recap of the NPI because if you look at this, you kind of have to either have, we need a 4 or greater because we want to be able to show an improvement, right? If they're only having mild symptoms occasionally, it's going to be very hard to show an improvement. So we're looking for people who have symptoms probably at least once a week, but ideally a little more frequently. And then if they're having them once or more a day, then they can be very mild. Obviously, we don't want people who have like once a day presence hallucinations or something that aren't, presence maybe, but there are some symptoms that are so mild that you wouldn't treat clinically, and those patients we don't want. We only want patients who you would treat clinically. But we also, need to have the frequency or the severity has to be, more than occasional or mild. The most common ones I think are probably going to be people having frequent or very frequent hallucinations that occur that are at least moderately distressing. Those are kind of the sweet spot, I think, because they will meet the criteria and will be able to show an improvement. And then they should know the way you make the scores, you just multiply the frequency by the severity. So any questions about any of that?
John, there's a question in the chat.
Oh,
Are you screening out Agent Orange or Camp Lejeune toxin exposure?
no, we want this study to be as relevant as possible to clinical practice in veterans, and obviously those people are part of normal clinical practice. There's no, I think, good reason to believe that they might have some, if they meet the modified UK brain bank criteria, perhaps someday we'll know that it's actually a different condition, but at this point we don't know that, and we don't want to exclude them. Thanks, Diana, for that question. We will, the pocket card I think was already shared, but we will definitely share it again. Let's see. Those are all the questions in the chat. Anything else anybody wants to ask? There have been, so far, I will say that we really appreciate those of you who have been able to send in referrals. I think we're kind of at about the right sensitivity and specificity ratio, because we are excluding a lot of the patients that you're referring, and that's okay. If we have to exclude 3 patients to find 1 patient to enroll, we'll do it. And obviously, as you get experience with this, you'll learn a little bit more about what we're looking for and why some patients are not eligible. So keep them coming, and keep the things in mind that we mentioned. We're not taking everybody, but these are kind of needles in a haystack, because for the most part, are you agreeing with me, Tamara? Or
Yeah.
Okay. You're, 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 in general, what we found is that primarily you're following patients chronically. But they have clear Parkinson's disease, responsive, CINAMED and everything. And they develop some mild psychosis, every couple months or whatever, they have either something that seems like a delusion or a hallucination, but they don't want to treat it, and you don't want to treat it either, and you follow them over time, and it slowly gets worse, and you decide, okay, well, we'll do the usual things. If they're on medications like amantadine or dopamine agonists or whatever, we'll try stopping those. If as the psychosis gets worse, but after excluding those things, and you've already kind of excluded delirium because we've been following that for a long time, and this is an ongoing problem. And you finally decide, okay, I have hit the balance point where if we try to decrease dopaminergic stimulation, then Parkinsonian symptoms become too great. So it's worthwhile adding an antipsychotic, and that's the patient we want. Who's not acutely psychotic, and it's kind of ideally chronically psychotic, and finally deserves treatment, or it's bad enough to treat. Sometimes you're in a tricky spot, because if you have a patient who doesn't meet the MPI criteria but wants to be treated, well, you got to treat them. You can still refer them, I think, because like I said, we'd rather miss out, or we'd rather exclude a lot of patients than miss out on a few eligible ones. But it is there have been times where patients just were not severe enough but still wanted treatment. Sometimes what you can do also in that case, you could try a cholinesterase inhibitor for a while, see if that, that's part of standard care, especially, assuming that they have some cognitive impairment as well. Or you could try low dose quetiapine. Some of us start with 12.5 or 25 milligrams of quetiapine. And sometimes that works. If it works and they go on for a while, and then their psychosis gets worse, and they're still on, say, 25 or 12.5 or even 50 milligrams of quetiapine, but their symptoms are not controlled well enough so that their MPI is actually within 4 or greater, making them eligible, then you could discuss with them that, by the way, if you're interested, we have this trial trying to figure out the best way to treat psychosis. And, if you just came off of the quetiapine for a week, you could be enrolled in this study, but it's going to help others and whatever.
Maybe we should see if anyone wants to bring up any questions in terms of the referral process, or. I'd be happy if there's referral centers that are on the call, what their experience with the process is, or if there's anything they think we can modify to make it easier to refer, or people that are sites that have received referrals. Our goal is to also hear from you all.
This is new, so we're learning too. Hopefully you guys can help us learn how to do this well as well.
We've encouraged John, had already been in touch with all the referral centers and encouraged all the sites to reach out regularly. So hopefully the sites will continue to do that with the referral centers are paired with. We also hope that the referral centers, when contact is made, that they'll respond and try to have some kind of ongoing contact between the two sides, because that can only help, we think.
Yeah, and I guess we asked for your patience because obviously the hub sites are frantically trying to find patients, and some of the study coordinators are very enthusiastic and really want to be successful. So they will reach out to you at times if and we've told them, that there's an appropriate amount of times to reach out and something. We don't want to. We know you guys are all busy clinicians, and we're not trying to take up too much of your time. We just want to make sure that the channels are open and that we can help you in any way we can. If you are getting more contacts and requests than you're comfortable with, please let me know and we can help fix that. So certainly don't want to lose any referring physicians because they feel like they're being bombarded by emails and anything.
Right. No questions?
There was no other documentation we needed to cover on the call besides what John and I presented already.
We
We can
have
pull
the
up
hub
hub
and
and spoke.
spoke listing.
Okay.
Yeah, that one.
Mhm.
And I mean, I can tell you that from our first meeting when we met with many of the spoke sites, we began immediately to receive referrals. So we want to thank you for that. To date, we have received 13. And of those 5 are still in process. So again, we want to thank you for those. They've come from various spoke sites. I don't have much detail to share other than please keep sending. We did also make a request, and you may be receiving emails from your study coordinators and your LSIs that just saying, I am here. If you have anyone, please proceed with referring. So don't be surprised if you get an email from your LSI based on the list that Annette is sharing right now. Again, the 15 sites with the 50 spokes that are assigned to the various 15 hubs.
A couple other updates. Richmond is actually going to be converting to a spoke, so the people referring the people referring physicians referring to them, I'm going to reassign you mostly either to Philadelphia or Gainesville. I'll let you know soon. And remember, we talk about them as spokes, but in reality, it's referring clinicians. You can certainly have more than one clinician on a given site being involved, and as you can see, that's some of the sites here. If you're comfortable talking to your colleagues and having them tell you about any potential subjects, that's fine. Or if they would like to become referring clinicians themselves, we'd be happy to talk to them. We have a few clinicians who are not even physicians. If you have a nurse practitioner who has a very busy Parkinson's practice, be happy to talk to them. Or a geriatric psychiatrist, or we need to fix Ergen's email address, which somebody spelled it wrong and his name incorrectly.
ERG. Yeah.
In his email.
Yep.
All right, I'll fix that after the call.
Sure. I don't know that we need to show the other spreadsheet. I think it's everything we need is here. Does anybody not know who their spoke site is? many people do we have on the 28 total?
About
Okay.
six are spoke providers, maybe more now. It was 6 earlier, up to 28. Let's see.
We have hub providers or
No, we have one hub I'm looking at, and the rest are spokes.
well, we got PJ and Jim are both hubs
TJ.
Yeah,
and Guari's a hub.
yeah. I did reach out to my counterpart in those two places and provided all the detailed information about our contact information, who we are. So I think hopefully we will get some referral and feedback from them.
Okay.
Thanks, PJ.
Thank you,
Great.
PJ.
Yes, yeah.
Thanks to all the hub providers who joined us as well.
Right.
And
It's
Marissa,
great.
I saw your note in the chat. Are you from the Bronx, VA?
Hey there, I'm from Birmingham, VA with Dr. Sung. I'm the nurse practitioner for movement disorders.
Okay, I'm sorry. I will add you to this list. I did not
Thank
have
you.
you. Thank
Thanks.
you.
Yeah, welcome.
Yeah, thank you for attending.
Birmingham.
It's under Gainesville. Up right below where you're.
Yeah.
Birmingham.
Yep, I'll add her there.
So we'll be up where you're recording this, obviously, Annette, and then you'll be able to share it with the rest of the everyone else after the call.
Yeah, so I'm not going to share it until tomorrow morning. I've got a couple documents I'm going to clean up.
Mhm.
And I'm probably going to have to convert this this recording like we had to on the first call. So we'll do that in the morning, and I'll send everything out to the listing that I used earlier.
So I guess I don't know if there's much else to cover. Again, we happy to hear feedback about making this as easy a process, particularly for the referring clinicians. And I mean, I kind of envisioned, I think we all envisioned that it wouldn't be any extra work. I mean, for 8 weeks, after you do the initial referral, you actually, don't have to have the primary responsibility for managing the psychosis because that'll be done by the study site. So it's just once you get through the initial just referral process, hopefully it'll be hands off, other than perhaps any Parkinson's disease medication modification that's needed, but hopefully that's nothing of significance for these medications.
Is it official yet? Is phase 2 and 3 out?
Not
It's-
yet.
Okay.
But any day, right, Tamara?
Friday's the review date, final review date,
Yeah.
the 9th.
Yeah. So
So for-
technically it's more than 8 weeks right now, but hopefully by Friday it'll be just 8 weeks. And obviously something that makes it a little easier to recruit, hopefully.
All right. Well,
Right.
Thanks,
You know what?
everybody.
yeah, thank you for attending and offering to help out.
Yes.
Yes, thanks, guys.
Thank you, everyone.
Take care, everybody.
Thanks all.
Bye.
Thank you.
Bye.